everything. This is the spectrum. We'll mention the most common one. Some might overlap. Keratinocyte is the main cell in the skin. Provides barrier, cytokines, antimicrobial defense. Melanocytes produce melanin pigments for UV protection. Langerhans cells, antigen processing, immune activation. T lymphocytes has what we call cutaneous lymphocyte antigens, also receptors. This is what makes some the lymphocyte, when you have a drug reaction, the lymphocytes going into the skin because they have these receptors. But the T lymphocytes are there also very important in immune regulation. We have commensal microbes, prevent pathogen colonization. We have nerve fibers, detect pain, touch, and temperature. We have sweat glands, cooling, autonomic regulation functions. We have hair follicles, stem cells, and hair production. The skin is not just there. It's a really, really specialized organ. And any of these can go wrong, and we'll see whether what happens if there's a defect with any of these. This is how the skin looks like. This is the epidermis. Let's get that very right. This is the epidermis, and here's the dermis. And then you have the subcutaneous tissue. Then it has oil glands. These are the sebaceous glands. It has hair follicles. It has sweat glands. And then at the base, normally at the base there, they have melanocytes. The thick skin, this is the kind of skin you find in the on the palm and on the sole. It's a thick skin. Yes, you can see what we call the stratum corneum. This is the thick, the corneum. Then there's a slightly lucid layer called stratum lucidum, and then there's this one that has granules, granulosum. Then this one that has spines, spinosum. Then this basally this is the basal layer. So there's a thin skin, the one you find over the body. There's a thick skin. The thick skin basically is that the stratum corneum is much thicker. Palm and the sole, other areas. The scalp has more hair. The scalp, you'll see a lot of more hair. It's again the same thing. We're showing the hair shaft, the sweat gland, and normally there's the pore there. So we'll see, like in acne, these pores get blocked, or we can have this getting blocked. Okay, and the dermis, normally there are two layers of the dermis, what we call the papillary dermis up here, and then down here is normally what we call reticular dermis. Now, these are how we describe skin lesions. This is how we describe skin lesion. When there's redness, we say this erythematous lesions, red. Macule is flat. If you touch it, it's flat, it's not raised. A patch is a large macule, it's not raised, but there's a discoloration more than 5 millimeter. A papule is a raised lesion, but less than 5 millimeter. A plug is a large papule. If a papule is more than 5 millimeter, we use the term a plug. A vesicle is a blister. A blister that's less than 5 millimeter, the term we use is a vesicle. A blister is something like filled with fluid, like serous fluid, like what you get when you have a scalding. That's a blister. So a big blister or a big vesicle, the term we normally use is a bullae. And stool. And when this papule and occurs suddenly, the term we use is a wheal or urticaria, like what you get with the acute drug reactions like anaphylaxis, this is urticaria. When you say this lichenification means it's a thickened and a rough skin. These are the clinical terms. These are the common clinical terms. So you see as when you're discussing how they appear clinically, it's either it's a macule or it's a patch, it's a papule or it's a plug. As we go along, we'll learn this. Then there's the microscopy. When the epidermis is thick, we use the term acanthosis. It's a thick epidermis. When there is keratosis. When the epidermis is eroded, that's erosion. When you have inflammatory cells in the epidermis, the term we use is exocytosis. So we'll say the cytosis. When there's swelling inside the keratinocyte, the keratinocyte is swelling, we use the term granules. Too much granules in this layer, we use the term hypergranulosis. It is low, there are less granules, we use the term hypogranulosis. Okay, hypogranulosis. Papillomatous or papillomatous means the surface is raised, there's epidermal hyperplasia, and also there's epidermal keratosis. In the thickening of the stratum corneum, the term we use is hyperkeratosis. If the thickening of the stratum corneum, but we can still tell nuclear, the term we use is parakeratosis. When there's epidermal intercellular edema, meaning the cells are separated or there's fluid in the epidermis, the term we use is spongiosis. Don't worry, as we go along, we'll notice the term. But when you're describing microscopic features, this is what we're going to use. When you're describing gross features, this is normally what we use. And for you, this is more important. This is more important than what we have here, because this is more of how we are going to describe the lesion once you bring us a biopsy. So, infectious disorders. Yes, infectious disorders. Sometimes they are normally lumped together with disorders of what we call epidermal appendages. Okay, impetigo, this is called by typically Staph aureus, but it can also be caused by Strep pyogenes. Very common in children, highly contagious. Face and hand, we end up with these pustules. Now we're using the term. Pustule here is a blister that is full of pus. Face on the hand, and we think what causes it is a toxin. It's a toxin that cleaves the proteins that make the keratinocyte to stick together. If there's another, this one keratinocyte, there's another keratinocyte, there's another keratinocyte. They are normally proteins, yes, that make the keratinocyte to stick together. They are called desmogleins. So there's a toxin. These bacteria produce toxins that attack desmoglein 1. Okay, so they start from a macule, going to a pustule, then you have an erosion, then you have a honey-colored crust. Crusting means that there is a erosion. And microscopy, what you see a pustule. You see a pustule. This is a blister filled with pus. Impetigo is common. Impetigo is one of the commonest skin infections, especially in children. And you're saying highly contagious. So in a nursery class, if one child has it, there are actually chances that it will be all over the place. Impetigo. Or you can have erysipelas. Erysipelas are caused by Staph aureus or Strep pyogenes. This is now in adults, face and scalp, and it's a sharply circumscribed erythematous plugs. Sharply circumscribed meaning you can see a very sharp area. I'm using the white skin because you guys are not professional dermatologists. It will be easier to see these features in a white skin. Sharply circumscribed erythematous. It's red and it's raised. And it's raised more than 5 millimeter. So the term we use is a plug. This is erysipelas. Then we have necrotizing fasciitis. Basically, when now the organisms come in, many potential organisms, you have pain following small injury, then the whole skin just laughs off. You have necrosis of the fascia, necrosis of the skin, and all this comes out. Progressive tissue necrosis and gangrene. This is what normally referred to as a flesh-eating bacteria. You have to do a very aggressive treatment. You have to do a wide, what's called, like this one, what they have done is they have removed, they actually removed all the dead tissue. So it's not just the skin, even the fascia, the subcutaneous tissue, and even the fascias are necrotic. Acne vulgaris, very common. Anytime you see us using a term vulgaris, we are referring to the common form of the disease. So there are other forms of acne. Yes, but the vulgaris is just the common acne. It's a common chronic follicular lesion in teens, typically males. We think this could be from occlusion of the follicles, and also there's a bit of heredity involved. It could be familial. And the main culprit here is a bacteria called Cutibacterium acnes, skin oil. And the product here is an irritant a substrate, an irritant substrate that causes inflammatory response. And on top of that, there's a keratin plug formation blocks sebum outflow. This one here. This one here. You remember these are the sebaceous glands. These are the sebaceous. This is where the sebum comes from. So what happens is that this is blocked here. So the sebaceous material that comes out accumulates here. That is what we mean by blockage of the sebaceous outflow. Okay? And that's why these conditions do respond to antibiotics. So they reduce the bacteria, they reduce the lipase activity. They do respond to retinoids or retinoic acid. Yes, so anti-sebaceous, they reduce the sebaceous outflow. They also improve follicular maturation. Follicular maturation is this hair follicle. This hair follicle here, this hair follicle you're seeing here. So these are the follicular cells that are seen there. Okay. And you have two forms, when it's open or it is closed. And the range what normally says it's an inflammatory response. You will get papules, you get nodules, you can get pustules, and eventually you have ulceration with the possibility of scarring. When you talk about a black comedon, this is a comedon that is not, or a blackhead, is a comedon that's not covered with the skin. So you have this black is the sebaceous material being oxidized and turning black. The open comedon here is the white head, meaning it's covered here by skin, so the pus now accumulates there. This is the sebaceous gland. This is the follicle. So when the follicle is blocked or the outflow is blocked, this material accumulates here. It can become pustular, meaning it can become infected with the bacteria, and this can actually also rupture. Okay. Acne is common. Acne is extremely common. And the form of treatment we use is towards the inflammation, the bacteria, and the issue of follicle maturation and anti-sebaceous. Or sometimes we combine them. This is a follicle. This is a follicle, and you can see the debris inside the follicle. And this is a narrowing of the outflow force, a common one. Yes, typical ones. You can see this is a pistule. This is a pistule. Yes, this is another. This is another pistule. This is another pistule. So you can see it's pus filled, but you can see the erythematous, the redness around it. Okay, acne vulgaris. Acne rosacea is different. This is most likely immune mediated, either immune mediated from a net defect or neurovascular hyperactivity or some body dysfunction. Or I think it could be also from the mites that normally have in the are inflamed because of neurovascular hyperactivity. They have persistent redness, again, due to neurovascular hyperactivity. They have pustules when they have neutrophils, and there's follicular rupture, and then skin of the nose to be thick. Okay, normally something we call rhinophyma. This one here. Okay, this is now rhinophyma. But you can see at the start, you have redness, and then here you can see a small blood vessels. Yes, you can see small blood vessels. This is a redness and telangiectasia. Again, erythema. This is a rosacea, acne. To differentiate it from acne vulgaris. Okay. When you have ringworms, these are ringworms are common. Mycosporum, trichophyton, epidermophyton, these are the species you have done mycology. They can they are named based on the anatomic side. So tinea corporis, tinea pedis, tinea onychomycosis, skin-loving fungi, dermatophytes. Okay, this is a tinea corporis is found in the skin. This is normally what we call potassium hydroxide preparation. You scrap this, then whatever you get, you put you dissolve with the potassium hydroxide. Then you look under the skin, so under the microscope. Sorry. So the potassium hydroxide removes the keratinocytes, and you're left with this kind of organisms, branching, septate. Branching and septate fungal. These are fungal hyphae. So if you see this under the microscope after putting potassium hydroxide, then you are sure you are dealing with a dermatophyte. This is onychomycosis. This is a nail infection. It can be this severe, it can be this mild. Onychomycosis. This is a tinea capitis. This one here, tinea capitis. This is on the scalp. Typically in children, you don't see tinea capitis in adults. And find an adult with tinea capitis, be worried that they might have immunosuppression. Tinea capitis don't respond very well to topical antifungals, so don't accept a prescription for topical antifungals. For the best, you have to give systemic antifungal. Okay, tinea pedis, you can also see it in between the toes. This is a tinea cruris, or the joker's itch. Tinea cruris. Okay, this is again another variety of Tinea corporis, and as the name says, this is more of like a ringworm, an erythematous, a sharply demarcated lesion, and there's a bit of scaling, there's some bit of thickening, what we call lichenification. Yes, this is another example of potassium hydroxide. Now, this is what we mean by a septate. It looks like bamboo. The bamboo looks and they're long and they are branching up and down. This is a potassium hydroxide preparation. Septate branching hyphae. This is what you see under the microscope. But there are other forms of how you examine how you investigate for fungal infection, including cultures. Sporotrichosis, basically fungus, but now has gone deeper into the subcutaneous tissue. It's a subcutaneous fungal infection. It's called dimorphic fungus because in human beings, it's a yeast form. In human beings, it's a yeast form. This unicellular, normally call them yeast form. When it goes outside, it becomes hyphal. It develops what we call hyphae. So it has both. It's like a shapeshifter. And we get it mainly when there's a thorn prick. Thorn prick, like that's why it's called rose gardener's disease. It could be lymphocutaneous, it can be just on the skin, it can be disseminated, and sometimes the term is sporotrichosis, but the best you can just remember it as a subcutaneous fungal infection. There are others like mycetoma, like Madura foot. Those are still subcutaneous fungal infections. Looks like something like this. Okay. This is now the lymphocutaneous form of a sporotrichosis. Because remember the beginning I told you skin lesion normally have long names and they'll get worse. Okay, then the verruca are just what? Direct contact by papilloma virus infection, HPV infection. Yes, the non-cancerous. Verruca vulgaris means the common word. Rough papules on the hand and the dorsum. Verruca plana means the flat one. So you have a flat papule. Then the palmoplantar one, these are scaly, looks like cones. Looks like cones or calluses. Condyloma, when you have them around the anogenital region, the term we use is condyloma. So condyloma cuminatum. So soft, tan, cauliflower-like masses. And the HPV types normally linked to lesion variants. 6 tends to give you condyloma. 1 to 24 and 44 tends to give you verruca vulgaris. I'll show you how it looks microscopically. Yes, this is a word. This is another word. Yes, this is another word. Now, this is a flat-topped word. So if you see this, a flat-topped word, this is now a very severe word. They're normally roughened. This is a anogenital region. The term we use is condyloma cuminatum. HPV words are common, from these mild ones to overt like this to very severe ones like that. Okay. Molluscum contagiosum, basically this is from a pox virus. Direct contact. The best way to remember is an umbilicated papule. And under the microscope, there's epidermal hyperplasia, and you see something called this. umbilical cast. You see there, it has an umbilicated center. And you look under the microscope, you see this and this cup-shaped format. This is a molluscum bodies from a pox virus, molluscum contagiosum. Okay. You have scabies. Scabies comes from Sarcoptes scabies. The hominis, this is the human variant. Can find them the hands, wrist, abdomen, and groin. The itchy rash normally is from the immune response. You may see barrows. They are normally highly contagious. Okay, like this one here, you can see barrows. Yes, you can see barrows. Yes. So this is from a parasite called Stachycoptes scabies. This is a highly contagious, associated with malnutrition, associated with the poor economic status. And the itching is not from the organism, it's from the immune response to the eggs and to the feces and to the structure of the animal. So those are infectious disorders. Acne vulgaris, the warts, the molluscum contagiosum, and of course the dermatophytes. Inflammatory disorders can be acute inflammatory dermatosis, like erythema multiforme. We are going to come to it. It's a hypersensitivity reaction. We think it's a type 4 hypersensitivity reaction with multiple lesions. It could be a reaction to drugs, it could be from infections like vascular disorder. And what you have are targetoid maculopapular lesions with a central pallor. Maculopapular means they are macules, they are flat, and the center seems to be a bit raised and erythematous, red. Stevens-Johnson syndrome is a form of erythema multiforme. Stevens-Johnson syndrome, basically here, there's mucosal erosion casting, but the involved area is 10%. When the involved area is 10%, Stevens-Johnson syndrome. Toxic epidermal necrolysis, there's necrosis, but there's a band-like presentation, means the involved area is more. So 30%, 10, toxic epidermal necrolysis. And we think this is a cutaneous lymphocyte antigen positive CD8 T cell. This is a hypersensitivity reaction. Type 4 hypersensitivity, you see vesicles, you see bullae, and there's a symmetric extremity. You see them all over. You see basal necrosis, you see blistering, you see erosions. And like this is a, yes, this, you can see it all on the skin. There's reddening, there's a bit of central pallor, and it's all over the body. So this is what you're seeing. So if you see more than more than 30%, we use the term 10. When it's less than 10%, we use the term Stevens-Johnson syndrome. And if you have extensive necrosis, then we tend to prefer toxic epidermal necrolysis, hypersensitivity reaction. Urticaria is just an allergic reaction due to mast cell degranulation. Lesions appear and regress within hours. So these are a type 1 hypersensitivity response. We're not going to discuss type 1 hypersensitivity. Basically, a type 1 hypersensitivity, so it's usually called urticaria, or they're called wheals. wheals or urticaria. They appear very fast because it's typical of a type 1 hypersensitivity reaction with production of a mast cells. Then you have perivascular infiltrate, you have edema, and of course you see neutrophils. When you see neutrophils, you're dealing with that type 1 hypersensitivity response. Yes, this is a swelling of the lips also as part of type 1 hypersensitivity response. This is angioedema. Yes, these are will. The raised erythematous papule. Okay. Sometimes you can have a mark, but they're normally papule because they are raised. Sometimes they can have a confluent. This is now confluent. And it occurs very fast. And when you remove the offending condition or the offending drug, this should respond much faster. Okay. Acute eczematous dermatitis, this is eczema. Eczema can be from the allergy, like what we have mentioned here. It could be from atopy, from people who are prone to getting allergic reaction. It could be from a drug. It could be from photosensitivity. It could be just an irritant. Okay, this is a delayed type of response due to from a Langerhans cells. So this is a normally, and this is a delayed type of response. So we think this is from memory cells driving an inflammatory response. Classical and crusted. It depends on the stage and the location of the lesion also depends with the age. So in young babies, typical atopic eczema will appear around the face, and as the child grows, it moves to the flexural area. So you see it around the elbow and the cubital, and also behind the knee. This is the popliteal area, and on the crura, that's on the groin. And also how it appears depends on whether it's a chronic phase, something that has been there for some time, or it's an acute phase. In acute phase, pruritic red papulovascular rashes that looks like crusted. In the chronic phase, because of too much rubbing and too much scratching, you normally got thickening of the epidermis. That's what we are calling acanthosis. You get hyperkeratosis. Acute eczematous dermatitis. This is acute eczematous dermatitis. This is the crusting part. But you can see mainly erythematous rashes all over the body. That's why at the beginning I told you some skin lesions looks the same. What you are going to see that, and you can see the terms you're using are almost the same terms. Red, papulovesicular, crusted, something like that, because those are how most of the skin lesions will appear. The defining and the underlying pathology will depend. If it's an infection, I'll call it differently. If I think this is an acute reaction, I'll call it differently. Okay. So this is the acute phase. It's acute phase. This is the chronic lichenification. Eczematous dermatitis. And you say the eczematous dermatitis could be from allergy, it could be from atopy. Atopy is just patients who are born with some hypersensitivity response. So this is what we got with the allergic rhinitis, allergic sinusitis, allergic conjunctivitis, and even asthma fits in here. And then you have the atopic dermatitis. Okay. Then you have the chronic inflammatory dermatosis. The best example here being psoriasis. Psoriasis is common. Here again, you will also realize that skin lesions in dark individuals, some of these features are not going to come out clearly. But do we see psoriasis around here? Yes, I see a lot. I'm going to speak for myself. I see a lot. Okay, so that the level of what you need to make a diagnosis is different. You need a specialist. You need a dermatologist actually who is aware of how these lesions appear. Then you need some biopsy for you to confirm that this is a psoriasis. Psoriasis is common. It affects the elbows, it affects the knee, scalp, lumbosacral, it can even affect the glans penis, and most of the time you also get some form of nail damage. So necrolysis means the nail is breaking apart, or is thickened, or is crumbling, or it has some yellow-brown discoloration. So some nail changes. There are several variants. We are not going to discuss that. There are almost 10 to 15, no, actually 15 different variants of psoriasis. That's not for you. The most one, the severest form is normally called pustular because you get pustules. You get, and you can have a systemic spread giving you what we call erythrodermic. You have a bigger chunk of the body being affected. The term you use is erythrodermic. We think this could be linked to HLA subtype, and trauma can trigger the lesions. We think this is a T helper 17 cells. Yes, T helper 1 produces macrophages. T helper 17 again macrophages. Necrosis factor driven keratinocyte proliferation, and they tend to respond. And you can see that this is what we are calling psoriasis. Yeah, this is what's called plaque psoriasis. We have these large crusting pruritic plaques that are silvery. Okay, and crusting. This is a plaque psoriasis. Okay, we think this is an immunological response or an abnormality to HLA subtypes. And these patients do respond to immunomodulators, including anti-tumor necrosis factor alpha, like etanercept. Okay, this is a pustular psoriasis. You can see pustules. You can see pus formed. Okay, this is what we call erythrodermic psoriasis. Almost like the whole body is now involved. It's a severe form of psoriasis. But again, you can see there, you can still see the pustules. This is a erythrodermic psoriasis. And when you look at under the microscope, you see this is normally what's called, this is the epidermis. This is the dermis. You see what we call sawtoothing. It looks like a sawtooth. And you see neutrophils. So they have some neutrophils, and on top of here you see a pustule. Looks like a collection of looks like a collection of pus cells. This is now a pustular psoriasis. It's very difficult to make this diagnosis unless you have some form of histology, because this can also be just an example of chronic eczema. Chronic eczema can appear like this. Okay, that is psoriasis. The other one for the chronic dermatosis called lichen planus. It's a common chronic immune-mediated disease. We think you have a polygonal papules, and sometimes it can affect the mucous membrane. Lichen means it's hardening and this thickening with draining. Lichen planus, like this. Yes, we said at the beginning that these skin lesions tend to look the same. So how you are going to differentiate this? This again are flat-topped papules that again have that silvery appearance. You have now differentiated from this. It's because the treatments are different. So when you're looking at dermatological disorders, you need detailed history. Really, really detailed history. Okay. Sometimes they can be obvious, like the ringworms will be obvious. Sometimes you might require more deeper, and you can still see the erythema, the redness is still there. Remember I said I'm choosing the white skin because it's easier to see these features. These are features that you're not going to see very well on a dark skin. And doing a dermatology in a dark skin, it is a different issue. This is lichen planus, flat-topped, purplish polygonal papules. Okay, it can go to. You can also see lichen planus also in the mouth and even in the oral and the genital areas. Lichen planus, a common chronic immune-mediated disease. Okay, and what you see mainly is what we refer to as lichenoid. Then you see a band of inflammatory infiltrate. Yeah, a lot of inflammatory infiltrate in the lichenoid interface inflammation. It's a bit different from what you have here. Here you're not seeing a lot of chronic inflammation. They are there, but they are not as much as what we have here. So this is lichenoid interface dermatitis. This is psoriasiform dermatitis. Seborrheic dermatitis, basically this is what looks like dandruff. Dandruff is a form of seborrheic dermatitis, very common. Normally you see them in sebaceous gland-rich areas, so the skin of the face, skin of the back, skin of the chest. Okay, we think this could be androgen driven, or it could be from a colonization with a bacteria called Malassezia fava. This has also been seen with Parkinson's disease, so we think dopamine deficiency also increases seborrheic dermatitis. The HIV forms some have a very severe form of seborrheic dermatitis. And the morphology, these are grease-yellow macules, you can get papules, you can see scaling crasps. It's just a form of the mild form is the dandruff. The severe form is crusting papules around the sebaceous rich gland areas. Erythematous macules, not really macules. Erythematous macules, papules, and there's a bit of crusting. It looks the same like any other lesions we have discussed. Again, John will actually show you this. So again, we don't like and don't accept prescriptions where somebody is giving you a drug where it's like they have a machine gun approach. There's a prescription, and this is a drug that has antibacterial, has antifungal, has a bit of antikeratolytic like salicylate. On top of that, they've put in a steroid. Basically means they don't know what they are treating. And that can be very bad because some of these are caused by infections. If you put a steroid on an infection, it will get worse. So here now we have to give you a drug that's going to at least deal with the Malassezia fava colonization. So either the ketoconazole or something like zinc. On top of that, we have to deal with the scaling part. So we have to give you something like a salicylic acid. Disorders of epidermal maturation. Ichthyosis basically is skin dryness. So the skin is scaly, like a skin shading off, the skin remains. So the epidermis and the stratum corneum remains intact. Epidermal maturation disorder, where with the hyperkeratotic scale, autosomal dominant, They're also the acquired. So the inherited and the acquired type. And this could be linked with the certain malignancies. And we think the cells they like each other too much. They don't want to be shed off. So they stick together for much longer. So there's this impaired discrimination. You have to shed off your skin so the new one comes in. So from the stratum corneum, from the stratum basalis, from the base, the cell has to mature and go and then become thin, and then it shed off so that a new one comes in. This is a disorder of epidermal maturation. This is an enzyme that breaks down cholesterol sulfate. And this cholesterol sulfate normally is what glues the cells together, so that if this cholesterol sulfate is left in place, then this cell, they stick together and they are not shed off. The end result is that you have an epidermis that is very thick, and that is the ichthyosis we are dealing with, the compacted stratum corneum with very minimal inflammation. This is the typical ichthyosis. Looks like a fish scale, all the scales of a fish. So this is the common ichthyosis. So we'll call this ichthyosis vulgaris, the common form of ichthyosis. There are other forms of ichthyosis. It can be so bad, like sometimes the X-linked, you are born with, a patient is born with a thick plug that covers the whole skin. Something is like they're born with a cutaneous scale, large cutaneous scale that blocks the whole skin. It can be that severe. But what we are showing here is the common form. It's much more than just a dry skin. Okay. When we talk about bullous disorder, we are meaning this is now a disorder that's forming blisters. We said a small blister that's less than 5 millimeter is called a vesicle. A vesicle less than 5 millimeter, I call it a vesicle. A bullous, if it is more than 5 millimeter, is a blister, but we call it a bullous. So bullous disorder, there are so many. There are so many. So the easiest way to explain the bullous disorders is choose the two. Pemphigus vulgaris, again, remember, in medicine, when we talk about vulgaris, we are referring to the common form of that disorder. So there's a pemphigus vulgaris and what we call bullous pemphigoid. So in this case, we have, these are autoimmune disorders. And we have antibodies against what's called spot desmosome. This is what glues the keratinocytes together, desmoglein 1 and desmoglein 3. So if there's an antibody against these particular proteins, the blister, the keratinocytes split. So here, they are okay. You can see this is a nuclear, there's a tight junction there. These proteins, the keratinocytes split, and you'll end up with fluid around here. And that fluid is what's going to cause a bullous. So if this bullous is occurring in the intraepidermis, meaning it either between the stratum corneum and the stratum lucidum, or in between the stratum spinosum, then that is a intraepidermal bullae. This is a pemphigus. And because you also need this desmoglein 3 to glue together the epithelial cells in the mouth, then pemphigus vulgaris will also present with the oral lesions. So the oral lesions comes in, and then both desmoglein 1 and 2 are affected, skin lesions appear. Nicole's sign means when you rub the top of the lesion, the epidermis comes off because the damage is just in the epidermis. This is pemphigus vulgaris. Now, bullous pemphigoid is different. The antibodies are against what we call hemidesmosome. Bullous pemphigoid are antigen 1. So this is what bullous pemphigoid antigen 1. So this is the keratinocyte. This is another keratinocyte. So between here we have desmogleins. Then this is the dermis. So what anchors the keratinocytes to the dermis is the BPAG1, or what we call the hemidesmosomes. So you have antibodies against this. The blister now will be between and the dermis. So dermis, epidermis, the blisters in between here, not between the intraepidermal. And this normally only on the skin. So you only find this reaction on the skin. So you get what's called a subepidermal bullae on the groin, on the axilla, and on the arms. And because this is not affecting the epidermis, you cannot scrap off the epidermis. That's the inosome, then the basal layer, then the basement membrane here. So if the damage is here, the blister will be formed here. This is a subepidermal blister. If the damage is here, then you'll have blisters in the intraepidermal layer. This is the intraepidermal blister. This is what we are seeing. When you look under this is a fluorescent microscope. Yes, you see the antibodies are around the keratinocytes. These are intraepidermal, between the epidermal cells. Here, the antibodies are beneath the epidermal. This is the epidermis. And then just beneath the epidermis, you get the antibodies. We say this is an autoimmune reaction. This is a bullous pemphigoid. And when you look at them, the blister is between the dermis. This one, the dermis is intact. The blister is below the epidermis, subepidermal. On top of that, you see some cells in that fluid. This is this bullous pemphigoid. So most of the other bullous disorders will fall within the spectrum. Yes, and under the microscope, you won't see the epidermis because the epidermis is very thin. The epidermis will come out, but for the bullous pemphigoid, is intact. This whole epidermis is intact. This is a bullous pemphigoid. There are so many other bullous disorders. This is the one that are common, and this is how we illustrate bullous disorders or vesicobullous disorders or a blistering disorders. And it looks like the person has been scalded. Yeah, they are forming blister. This is where the blistering disorders or vesicobullous disorders or bullous disorders. Okay, the next one, you can have benign epidermal tumors, seborrheic keratosis. These are benign epidermal tumors in the adults. You find them in trunk, in mostly on the trunk, and sometimes they could be a sign of a sign, meaning this patient has some form of a carcinoma, some form of a malignancy. Then you are getting a tumor necrosis factor alpha being released, and tumor necrosis factor now causing a. Okay, this is a seborrheic keratosis, and when you look under the gross morphology, they normally turn brown plugs. Looks like they've been like somebody took mud and actually stuck them on the skin. They have this stuck-on appearance. Don't confuse them with melanomas, but please also don't assume they are seborrheic keratosis while they're actually melanomas. Basal hyperplasia horn cyst hyperkeratosis is basically epidermal neoplastic lesion of the epidermis is benign. Sign meaning if you see so many of them coming all of a sudden, like okay, acanthosis nigricans basically is a hyperpigmented plaques in the flexure. We think again this could be inherited. I've seen other congenital malignancy, and if you see it and your person is slightly older and they're complaining of a dyspepsia or a bloating or epigastric pain, be careful. It could be a sign that they're having a gastric carcinoma. Yes. So again, it could be a carcinoma. Like this one, this is a patient with, if you remember, polycystic ovarian syndrome. In polycystic ovarian syndrome, they had diabetes normally just around the corner because these patients do have hyperinsulinemia with the insulin resistance. Yeah, so this dark brownish pustules. This patient also has skin tags, okay, around the neck and also this around the axilla. The freckles around they look like there's just some darkening, and that's why we are calling it nigricans, demarcated typically around the axilla and also around the neck. Okay. This is a patient who had a polycystic ovarian syndrome. Okay. Premalignant and malignant epidermal tumors, you can have what's called keratoconthoma. Keratoconthoma, some people think is just a squamous cell carcinoma that is well demarcated. Rapidly growing crater-like nodule, it may evolve into squamous cell carcinoma. It must be removed. It looks something like this. So if you see something like this in an adult, be careful. You could be dealing with a form of squamous cell carcinoma we call keratoconthoma-like center. Okay. Actinic keratosis basically is these plastic epidermal cells, but now limited to the epidermis. It has not gone into the skin, into the epidermis. When you have a dysplasia, you know the issue of dysplasia. Just a dysplastic epithelial lining without subepithelial involvement, that is dysplasia. And when you say actinic, anytime you refer to a term actinic, you're referring to sun exposure or related to the sun. So related to the sun, the term we use is actinic. Keratosis, basically just thickening of the epidermal cells and also with the abdominal keratinization. We think this is premalignant and this normally what leads to squamous cell carcinoma. Yes, like this. This is a part of it's a hand. You are seeing this now on the volar aspect. Sorry, on the dorsal aspect of the hand. Okay, this is easier to see. It looks the same like any of the lesions we have seen, and that's why at the beginning I told you, skin lesions can be very difficult to deal with. They're normally difficult in that I'll wait for Kivali, as I explained, in that they almost look the same. Yeah. Making a difference between even a bullous disorder that has been chronic and this actinic keratosis means you have to take a lot of detailed history. Kivali is asking, associate tumor with painless growth, but is there the same thing that happens with skin tumors? I think that is correct. If I see a painful lesion, a very painful lesion, my first thinking would be not carcinoma, unless it's growing extremely fast. By the time I'm seeing a painful malignant lesion, a tumor involving the nerves. So that still holds Kivali. That painless lesion tends to be more ominous than what I would say a rapidly growing painful lesion. Painful lesion are seen much with inflammatory. Yeah. And you can even see the names. The names look long and weird. Yes, but bear with me. That's how skin lesions are normally named. So when you see actinic, you are referring to something related to the sun. Keratosis is excessive keratin and also excessive epidermal thickening. But in this case now there's a dysplasia. So we think this is a premalignant condition. And this was going to lead to squamous cell carcinoma. Squamous cell carcinoma, before we go to squamous cell carcinoma, let's look at disorders of pigmentation and melanocytes. When there's no pigment, this is vitiligo. Irregular, completely pigmented patches is a patch. They are not raised. They are not plaques. If you touch it and it's very flat, then we use the term a patch, and it's large, more than 5 millimeter. It's a regular, completely pigmented patch, may affect any race. There's normally some familial predisposition. Unknown etiology, it could be possibly autoimmune disease where and in the affected areas biopsy, please biopsy from the abnormal side to include the also the normal side so that we compare. Or take a biopsy from vitiligo could be segmental, meaning it's almost duplicated on both sides. Yes, it's duplicated on both sides. Normally around the fingers, around the hand, around the perioral or perigenital areas. This is the asymmetrical, meaning you are seeing it, but there's no duplicate of the image. That is very important because this one can regress. This one tends to be permanent. Okay, I remember this. If you guys still remember Michael Jackson, apparently Michael Jackson had this disorder. So it was decided that instead of dealing with it one by one, then we just remove the pigments from the remaining skin so that and everything now remains white. That's what he said. This is a loss of pigment. This is a vitiligo. When you have too many pigments or the pigments are too many, Kivali, that's a very good question. Kivali, it brings us what we are saying here, that these things look all the same. And they get worse. They get worse, Kivali, if you put steroids on them. Steroids will modify how they appear. Steroids will remove the erythematous changes. Steroids will remove the inflammatory response. But the disease will still be there if it does not respond. A skin lesion on the scalp, yes, tinea capitis. And as I said, tinea capitis don't respond. Tinea capitis also we see it mainly with children. Be careful calling something tinea capitis an adult unless they are immunosuppressed. So it looks like tinea capitis and an adult. Yes, be careful calling it tinea capitis. Now, if you find tinea capitis and you confirm this is tinea capitis, don't use topical antifungal. Use now systemic. Give the itraconazoles, give the fluconazoles, and give terbinafine systemic, or give crisafulvin for much longer time. But if things are not working out and they're giving treatment, you cannot give treatment for 10 years without response. It means you have the wrong diagnosis or you're using the wrong medication. Biopsy the lesion. So Kivali, I would say those are the kind of times now when things are not adding up, you do a biopsy. Or if things are not very clear, that's normal how it works. If not sure, biopsy the lesion. We will help you make a better diagnosis. Nevus or freckles, sorry, these are not a mole, sorry. It's not mole. These are freckles and lentigo. Remove that one. Freckles are macules, turn red to brown. We see this in too much melanin. If melanocytes are producing too much melanin, they will give you a freckle. Now, if there are too much melanocytes, but not at the malignant form, fuel on the skin and the mucosa. So now this is too much melanin. Excess basal melanocytes. So we end up with some brownish discoloration. They are macules, they are flat. And the cafe, this one is a bit larger, it's independent of sunlight. We see this with what we call neurofibromatosis 1, cafe au lait spot. Cafe means a coffee-like or brown coffee, not nevus. We are coming to nevus. These are freckles and lentigo. These are freckles. Very much related to redheads. These are freckles. Okay. This is a lentigo. This is a lentigo. You can see the sharp macule here. This is what we've done with what's called a dermatoscope. Another lentigo. Another lentigo. Vitiligo, no melanocytes, no melanin. Freckles and lentigo, too much melanin and too much basal layer of melanocytes, only in the basal layer. Okay, and nevus now you have a benign neoplasm of the melanocyte. They're too much, they're normally round, they're evenly pigmented, and then they progress down. As they go down, they mature. Yes, now is this a neoplastic lesion of the melanocytes? We can have melanoma developing from a nevi, the so-called a dysplastic nevi. Dysplastic nevi. Okay, so this is a junctional nevi. Again, remember, you can see this looks the same as our lentigo. So the difference will be on the clinical scenario and also on the biopsy, because on the biopsy now, I'm seeing melanocyte in the dermal junction. Then I know this is a junctional nevi. A compound nevi now is much larger, but the margins are well and it is smaller. Then now we are seeing melanocytes at the dermal epidermal. This is a compound nevus. Then this is intradermal nevus. Again, this one does look like seborrheic keratosis. Again, the difference is the size, the way it's raised. These are plug now. This is a papule, and you can see that most of the you saw a certain post on Instagram how you can differentiate skin tumors from fungal skin infections. the difference from looking at the margins and the color. Kivali, I'm coming to that, but I don't think that's unless you're a super specialist and you have specialized cameras like this. This is from what's called a dermoscopy. Dermoscopy. You magnify the area and then you also look under the microscope so that you can see the margins very well. We look at what they mean by the issue of the margins. You have brought a very good, but I don't think it is based on how to differentiate a mole from a melanoma. We are coming to that. We're saying when it is benign, the term we use is a nevus, but you can have a dysplastic nevi giving you melanoma. So you want to say, how do you say that this is just a nevus and this is not melanoma? It's how do you say this is a nevus and not melanoma? Because the nevus is, this one is still, even if it looks cellular, you remove end of story patient. Melanoma is an extremely serious condition, as you're going to see. So Kivali, I don't think it differentiates skin tumors from fungal infection. I would use it, the issue of the margins and the color, to differentiate a nevi from a melanoma. And that's when I'm coming to that. Okay. So, a neoplastic benign tumor of the melanocyte is called a nevus. If there are many, they are called nevi or moles. Okay. Hemangioma is basically a benign tumor of the blood vessels. Okay. Strawberry hemangioma occurs at birth, usually regresses with a year. Within a year, this is a hemangioma. You don't need to biopsy it, just look at it. It's purplish, it's violaceous. It can be a lot sometimes. This one, they do mature and regress. So disorders of pigmentation, but not really pigmentation, you know that the skin looks different. But this is not from the pigment. This is not from melanocytes. This is from a blood vessels. Melanoma now. Melanoma is a malignant tumor of the melanocyte. All ages, but peak sun exposure, sunburns, fair-skinned individuals. So in whites, and then in RAS, in BRAF, in RBG, in cyclin-dependent kinase inhibitors, and even TAT, telomerase enzymes. And the prognosis, the most important prognostic marker is the melanoma. We are already worried. All you need to say is an melanoma is already malignant. Okay. There are so many possible mutations. You can have RAS mutation, you can have PI3K mutation, you can have AKT mutation, you can have. The ones that are listed here means they are drugs they can target these particular inhibitors, like BRAF inhibitors. So you do BRAF immunohistochemistry in the melanoma. If it's positive, then they respond this drug because melanomas are extremely, and that's why again Kivali, I would rather detect whether I'm dealing with a mole or I'm dealing with a melanoma, because those are diametrically opposite. Okay? Now, how do you look at that? Now, this is what you're looking for. Is it a melanoma or is it just a mole? You look for the asymmetry, the shape or the color. So you see some areas red. Then the boundaries are not very clear. The borders are irregular. The colors variegated, meaning there's a mix of colors. It's not an homogeneously black lesion. It's more than 6 millimeter. It's elevated. It's bleeding. There's some evolution. There are some textural changes within the lesion. So yes, Kivali, these are the things you're looking for. So A, B, C, D, E. If I see asymmetry, I see irregular border, I see variegated color, it's more than 6 millimeter. And it seems the patient tells you it used to be small, now it's evolving, or now it's becoming more itchy, or now it's bleeding, then I know it's evolving. Then it used to be flat, now it's becoming thicker. Yes, then you know this one now is not just a mole. This could be a melanoma. This could be a melanoma, the ABCD of a melanoma. Okay, and this we have to mean by this the symmetrical, well demarcated. The borders are very, very, very nice. Yes, and you can see just one color. Here, the margins are not very clear. Even the borders are not very clear. You see some ruggedness over there. Yes, the borders are very irregular. Some of it is here. And even the colors here looks slightly darker. This one looks slightly brownish. That's what we are calling it, variegated. So if I see this, then I'm worried that I'm dealing with melanoma. Melanoma has, again, you have said, a terrible prognosis. These are still melanomas. You can see the irregular margins. You can see the variegated appearance. And sometimes you can even have a melanoma that is not pigmented. This is what we call a melanotic melanoma. Again, I said at the beginning, skin lesions don't play very nice. They don't read books. So it doesn't mean that it has to be black for it to be called melanoma. It can decide not to produce any pigment, but still, if you do special stains, you will still confirm that these are coming from melanocytes. Yes, melanomas can occur on the skin, can even occur in the mucosa. And in the mucosa, this is in the palate, they have a dismal prognosis, terrible, terrible prognosis. This oral melanoma, you can find the cervix. I have seen this also in a primary one in the colon. Okay. This is around the nail. This is what we call subungual melanoma. Subungual melanoma. So if you see something like this, don't dismiss it as a onychomycosis. Don't dismiss it as fungal. And the problem is this size most likely has already metastasized. We'll see the size that metastasizes. It's not 10 centimeters, not 100 centimeters, it's millimeters. Millimeters. So now you are seeing the dermis, the keratosis, but you have abnormal cells, very large cells, and they're producing pigment. Yes, this is melanoma. It's melanoma. But melanoma, again, tends to give us a lot of problems as pathologists. It can take any shape. In fact, if you see a patient who comes in with a malignancy that you cannot say is coming from where, you are finding it in the nodes, in the bones, in the lungs, in the liver, and you cannot see where it's coming from. First of all, look for things like this. Look for the palm, you see something like that, and that could actually be the source. Depth of invasion is the most important factor. And this can be either by Clark's level or what you call Brestow's thickness. You measure the thickness. If your patient has metastasis, especially the inguinal lymph node, it's a worse prognosis. If the lesion is ulcerated, it's a worse prognosis. If the lesion has too many mitoses, it's not showing signs of regression, has very little, male tends to do poorly on several things. And even the location, if it is in the mucosa, bad prognosis. If that around the lower limb, most important factor of prognosis. And you can see see it's just here. Or level 2 now is going down. It's in the papillary dermis. Level 3 is going in the papillary subcutaneous tissue. You can see the 5-year survival rate changes from 90% in level 1 to 30% in level 2. And something of 4 millimeter. 4 millimeter, more than 4 millimeter is a stage T4. T4A without ulcer, T4B with an ulcer, giving you a 5-year survival rate of less than 30%. And that's why, again, as Kivalia said, we need to make this differentiation. This has to be made clinically so that you know which one to biopsy, because one, this is a melanoma. Other malignant neoplasms in the epidermis, you can have a layer of basal cell layer of the epidermis, giving what's called a basal cell carcinoma. Elderly, sun-exposed, fair complexion, could be from immunosuppression. It could also be when you have a condition where you have disorders of DNA repair. DNA repair genes are abnormal, so that when you had this mutation accumulate, failure of the DNA repair genes, you have growth raised pale nodules, there's telangiectasia, sometimes they're normally ulcerated. Now, basal cell carcinoma is what almost never melanoma. These are the so-called rodent ulcers. Like it has been again, fair skin individuals are the one who tends to get mainly the skin carcinomas. This is a basal cell carcinoma. The cell that's abnormal is the basal layer. For you outside there, it's difficult to make this diagnosis because this could still be squamous cell carcinoma. Do a biopsy. We will inform you of which one it is. Squamous cell carcinoma, this is now from the keratinocytes. Again, sun exposure, fair complexion, chronic skin ulcers like burns, sinus tract like osteomyelitis, arsenic, burns, radiation, immunosuppression, and of course, xeroderma pigmentosa. And the precursor is actinic keratosis, or what's called a Boyan disease. Boyan disease basically you have a full thickness displaced of the skin. So sun-exposed areas is a tan nodular mass. It can be ulcerated. And of course, now this is arising from keratinocytes, and the keratinocytes are this one now. It still looks like the rodent ulcer, but now when you biopsy it, we see keratin pearls. You see now the cells look different, and this is the skin, these are the sebaceous glands, and there's invasion into the epidermis. Squamous cell carcinoma, very common in our setting, especially in the setting of chronic and also chronic osteomyelitis. You can get lymphomas in the skin, and this is normally what's called cutaneous T-cell lymphoma. Yes, it's a spectrum of cutaneous T-cell lymphomas. So mycosis fungoides, or what's called Sézary syndrome. Sézary syndrome is when this goes into the when it goes into the blood. Mycosis fungoides when it's just on the skin. This is a lymphoma of the skin. It could just be primarily on the skin, or it can spread. That's what we call mycosis fungoides, a cutaneous T-cell lymphoma. Basically, when you look, yes, and that's why we said this could look like a drug reaction. Yes, large macules with some papules, extensive erythematous lesion involving almost all the body, but typically in the elderly. And if you look at the epidermis, and then you confirm this is what's called a CD4, you confirm that these cells contain are mainly CD4 T cells. CD4 T cells. So it's the abnormality of CD4 T cells infiltrating the skin. This is a This is mycosis fungoides. When it goes to blood, then the term we use is a Sézary syndrome. That's the leukemic form of it is the Sézary syndrome. Tumors of the epidermis, you can have epithelial proliferation in the epidermis. Yes, again, this is common. Don't confuse this with a mole, but it's benign. We have fibroblasts, we have histocytes. Okay, very common. Young women, especially the leg and also the upper arm. Looks like this. And when you look under the microscope, you are not seeing epidermal lesion. Now you are seeing something in the dermis. You see spindle fibroblast, you see epidermal hyperplasia. This is the benign form, and it's a fibrous lesion. The dermatofibrosarcoma now is more aggressive, it's bigger, it's invasive. Don't worry about all those. This one I'm just telling you because, again, this is common, and this patient will come to you because we also use tyrosine kinase inhibition. This is the imatinib, the one we use for CML. We also use it here as a targeted therapy. Farm not used, but now you have a fatty invasion. This is dermatofibrosarcoma population. Extremely common. You'll definitely see it. It's not, it doesn't metastasize, but it won't recur a lot. The same drug we use for CML is the same drug we use here. For CML, we use a tyrosine kinase inhibitor. The same drug we use also for, they have met GIST. You have met GIST in the GIT. Yes, the same drug we use. So it's also the same drug we use for dermatofibrosarcoma protuberans. You can see this is the skin of the scalp. This is the skin of the scalp. You can see it's hairy. And then there's a nodular tumor here. And this is all tumor. So it's a large protuberant tumor. That's why it's called. This is tumor. Looks like the flesh of a skin, of a flesh of a fish. This is dermatofibrosarcoma protuberans. This one is common. And if you see a lesion like this, large protuberant lesion on the skin that has been there for a long time, now it's ulcerated, your first diagnosis should be this. It should be large. It can be small, but tends to be typically be large. Finally, we have adverse cutaneous drug reactions and soluble changes in the skin and mucosa caused by either systemic or topical medication. This is common. We'll see it a lot. It could be either be a type 1 IgE-mediated pathology like the urticaria or the angioedema, or it could be a type 4 cell-mediated reaction like in immobiliform, scalciniform xanthemas, or SJS10, this one you have discussed, or from what we call drug reaction with the eosinophilia and systemic symptoms or systemic syndrome, DRESS. And the key assessment didn't have this lesion. Then after some time now, the lesions start appearing. So the drug timeline, you start that, the stop that, and the first appearance of the symptom much later. There are so many types of acute drug reaction, I'm just mentioning a very few. This is a xanthematous. You have a meso-like rash, 5 to 14 days. So the timeline matters. Penicillin, sulfonamides, and NSAIDs. Then you have the urticaria, the acute setting. Again, tetracycline, NSAIDs, pseudoephedrine, and even things like penicillin, acute setting. That these patients get this lesion at the same spot. Every time they take this drug, the same spot gets involved. That's normally what's called a fixed drug eruption. It can have wheals or you're carrying in the same reaction with the eosinophilia and systemic symptoms or systemic syndrome. 2 to 8 weeks, you can see the timeline. We see this again with allopurinol, the one we use for it's a uricosuric, the one we use for gout, and also for tumor lysis syndrome. You also get with the anticonvulsant. So these patients normally have facial swelling, they'll have eosinophilia, and they'll have one other organ being affected, like hepatitis or nephritis. So this could be a feature of nephritis. And this also what you see, acute generalized eczematous pustulosis, more than 48 hours. We see this with beta-lactams. So this antibiotics, the group of cephalosporins and penicillin, and then also the macrolides. And this 28 days, typical of, you also see this a bullous. You get a bullous, you can get eczematous reactions, necrosis is when you're having 10. Toxic epidermal necrolysis, and when they say extensive skin, and these are severe drug reaction. At the level of 10, at that stage. So this one normally have to be treated like 30% burnt surface area. We also use burnt surface area in these cases. I've mentioned the most common. I've ignored the ones that you really don't need at your level. Skin lesions are convoluted. There are many, they look the same, and even on histology. And then you see the problem is they can have secondary changes. So somebody has tinea corporis or tinea capitis. You either scratch too much and the bacteria comes in, it gets a secondary infection. Or from the scratching, you end up with the epidermal thickening, which might distort the picture when you look at it much later. Or you give some treatment that partially treats it and modifies it. That's normally the issue there, skin lesions, that they can have secondary changes. Any question? Okay, if there are no questions, I'll send you the notes for your revision. I think this should be one of our last lectures. I'll wish you the best on your I think the next cut and the exam. If you have any issues, please tell us early. Any issue that you think we can help you around with, tell us early. Yes, we want you all to move to the next class. Yes, life is tough enough. Yes, Timothy.
Yes, thank you for the lecture. So I had a concern raised by someone that the current workload is too much, and they were asking if maybe the lectures that were taught today or tomorrow should not be included in the card. It's just a request, but we can still read. There is no problem.
Oh, for the lectures that were. So which topics particularly, so that I go talk to the exam officer?
For example, the lecture that has been taught today, and the one that's remaining, that maybe they should be in the exam and not in the class that we are doing on Wednesday. It was just a request because most of the members were saying that the workload is a bit extensive and they might lack the time to read everything.
Let me write that one down. So the one you're having tomorrow is? Your final one will be which one?
I think it will be TB and skin disorders or something like that. And the one that we've had today, and the one that we've had today.
So the one for today and tomorrow should not be in the card that's on Wednesday.
Yes, but the ones that have been taught can be in the card.
Okay.
Yes.
I'll talk to the exam officer and inform Faith.
All right. Thank you so much.
Okay. Okay.